you all doing well and staying safe. So today I'll be starting a class on head injury. It is a very important topic, so please be attentive. Let's come to the definition. Head injury, it is the injury to the scalp and the brain. So it will be scalp laceration, skull fracture, and direct injury to the brains, which leads to bleeding in the brain and hematoma. So let us just go, before we proceed with the topic, let's just have a brief review of the anatomy of the brain. So the brain, it has three parts, that is the cerebrum, cerebellum, and the brainstem. Cerebrum, it is the largest part of the brain, which is composed of the right and the left hemispheres. And the cerebellum, it is mainly located under the cerebrum. And brainstem, it acts as the center that connects the cerebellum to the spinal cord. And the functions of these parts of the brain, mainly the brain stems, it responsible for sleep, heart rate, breathing, and the cerebellum mainly responsible for balance, coordination, and the cerebrum like temporal lobe mainly for memory, frontal for attention, motivation, emotional judgment, problem solving, decision making, and language, and the motor area for voluntary movement, parietal lobe for sense of touch, occipital for sight of vision. Okay, so just a brief about meninges. Meninges, it is the membranes that covers the brain and the spinal cord, and it has three layers, that is the durameter, arachnoid, and pyometer. Now it has two main functions, that it's mainly it provides the supportive framework to the cerebral and cranial vasculature, that is mainly to the brain and the cranial blood vessels. And along with the CSF, it also protects the central nervous system from mechanical damage. Now, the incidence of head injury. Every year, almost 250,000 of people are hospitalized due to head injury, and 50,000 of people die due to head injury, and almost 80,000 to 90,000 people sustain long-term or lifelong disabilities because of brain injury in every year. Now, the classification or the types of head injury, I'm going to discuss one by one. That is the scalp lacerations, where there is it is one type of the minor type of head injury or head trauma. Now mostly it is associated with profuse bleeding, since the scalp, it contains many blood vessels, and the major complication it's always associated with scalp laceration is infection. Skull fractures. The skull fractures, it frequently occurs with head trauma. So fractures, it can be closed or opened, it depending on the presence of skull laceration or extension of the fractures into the air sinuses or dura. Now the types of skull fractures. Types of skull fractures can be linear. Linear, which means that there is a break in the continuity of bones without altering of the relationship of parts. So mainly it is caused by low velocity injuries. Next, that is depressed. So there is the inward indentation of skull, which is mainly caused by powerful blow. Next, that is simple skull fracture. It is the linear or depressed skull fractures without fragmentation or communicating laceration, which is mainly caused by low to moderate impact. Next type, that is the comminuted, that is there will be multiple linear fractures with fragmentation of bones. to many pieces, which is mainly caused by direct high momentum impact. The last type, that is the compound skull fracture. Here in compound skull fracture, this is the depressed skull fractures and skull laceration with communicating pathway to intracranial cavity which caused by severe head injury. Next, that is the minor head trauma. In minor head trauma, here the concussion it occurs, which is mainly it is a sudden transient mechanical head injury with disruption of the neural activity. So there is a changes in the level of consciousness, and it results from direct blow to the head or the gunshot wounds. Then the last type, that is the major head injury. In major head injury, a bleeding bruise to the brain, which is mainly caused by direct impact to the head. So it includes the cerebral contusion, or hematoma, and laceration or cut or tears in the brain, which are generally associated with close injuries. Next, that is the focal injuries. Here in focal injuries, hematoma is always, it occurs. So in focal injuries, we'll talk about the epidural hematoma. And epidural hematoma, it results from bleeding, which is mainly between the dura and the inner surface of the skull. So the hemorrhage, it occurs in the epidural space. Please remember that I am repeating the same sentence. That means it is results from the bleeding between the dura and the inner surface of the skull. That means between the dura and the skulls. Next, subdural hematoma. A subdural hematoma, it occurs from bleeding between the dura mater and the arachnoid layers of the meningeal, that is covering the brain. So it results as the acute subdural hematoma, subacute subdural hematoma, chronic subdural hematoma, or intracerebral hematoma. In acute subdural hematoma, it's always associated with the major head injury. So here the symptoms, it developed immediately over the 24 hours to 48 hours. And here the symptoms, there will be changes in the level of consciousness, there will be changes in the pupil reaction, the patient will experience coma, increased blood pressure, decreased heart rate, slow respiratory rate. So there's increased blood pressure mainly because of hematoma. So in subacute subdural hematoma, so this is less severe head injury or head trauma. So the symptoms, it begins between 48 hours and 2 weeks after the injury. So the sign and symptom is always similar to acute subdural hematoma. And in chronic, so this minor head injury, so the symptoms can take within a week or a month to appear after the injury. So in the intracerebral hematoma, it occurs from bleeding within the parenchyma, the brain. So it usually occurs within the frontal and the temporal lobes. So we'll talk about the risk factors. Risk factors can be motorbike accidents, falling down a few steps or falling into a hard object, firearm relating injury, assaults, sport related injuries, and recreational accidents. So all these risk factors, it can lead to head injury. Before we proceed with the pathophysiology, let's talk a bit about the mechanism of injury. The mechanism of injury, two things that happen, that is counter cope injuries and penetrating. Cope counter cope injuries. Now here, the cope, which means that it occurs to the injury that occurs to the brain directly. And countercope, it occurs on the opposite side from where the impact occurs. So cope counter cope, that means the injuries, it occurs in both. That means direct to the brain and opposite from where the impact it occurs. Now here in cope counter cope, two things happen, that is the primary injury and secondary injury. In the primary injury, damage to the brain and skull due to blow. Secondary injury, that is the hours to days after the initial impact, when there is the continuing of the injury from edema, inflammation and hemorrhage within the brain. Okay, next we'll talk about the pathophysiology. The brain will always suffer traumatic injury due to risk factors or the causes. Then there will be brain swelling or bleeding inside the intracranial volume. So there will be rigid cranium which allowed no room for the brain to expand of contents. So there will be increased intracranial pressure. So there will be pressure on the blood vessels in the brain, which causes the blood flow to slow in the brain. So because of the slow in the blood flow, so there will be cerebral hypoxia and ischemia, it occurs in the brain. Then there will be increased intracranial pressure inside the brain, or sometimes it may lead herniation of the brain. And finally there will be cerebral blood flow stop, or there will be brain death. Now we'll talk about the clinical manifestations. You will see that in skull fractures, mainly there will be facial paralysis because of the fractures in the skull. So there will be, especially when it involved the bones in the face. So you will see there will be a battle sign. So what is battle sign? That is, there is a oral shaped bruise that is mainly behind the ear in the mastoid region. So this when you will see this bruise in the mastoid region, it indicates that there is a fracture at the bottom of the skull, that is the middle cranial fossa of the skull. Then rhinorrhea, that is when there is a leakage of the CSF from the nose. So what happened? Normally the CSF, it is the protective fluid that covers the brain. So when there is fractures to the skull of the face, so what will happen? There is a leakage of the CSF. That is, you can see in this watery fluid that is can be coming out or leakage from the nose or sometimes from the ears. So in the skull laceration, you will see there will be profuse bleeding. In minor head trauma, there will be concussion. There will be persistent headache, lethargy. Then there will be decreased loss of consciousness. In major head trauma, consciousness and laceration, it occurs. There will be hemorrhage, hematoma, and there will be increase in the intracranial pressure. In diffuse axonal injury, same thing. There will be herniation of the brain, cerebral edema. In the epidural hematoma, unconsciousness at the scene, headache, nausea and vomiting or focal finding can be seen here. In the subdural hematoma, there will be increased intracranial pressure, decreased loss of consciousness and headache, drowsy and confused, and the pupil dilates and fixed. So all these signs and symptoms, it occurs because mainly the brain it affects. So all the functions of the brain, it gets affected. So now when there is a brainstem contusion, mainly a client immediately becomes unresponsive or partially comatose, or there will be alter in the level of consciousness for several hours, days or weeks, or sometimes there will be permanently comatose. There will be neurologic abnormalities, and sometimes there will be loss of normal eye movement. Now, to diagnose a case, first of all, we need a thorough history and physical examination of the patient, a blood test, blood routine of the patient, and a CT scan. So CT scan, it is the best diagnostic test. Why? Because that mainly to evaluate for the craniocerebral trauma, because it shows the presence and the nature or the location of the acute lesion. So it helps actually in the ongoing management of the patient with head injury. Now the MRI or the magnetic resonance imaging, this mainly it is used to evaluate patient with head injury when a more picture of the anatomic nature of the injuries is warranted. So when we want to see the anatomy of the brain where it gets affected, so we will go for MRI. Now cerebral angiography. This is mainly, it is used to visualize the blood vessels or to identify the supratentorial or the extracerebral and intracerebral hematoma within the blood vessels of the brain or around the brains. So the next, that is the transcranial Doppler studies, which is mainly to allowed for measurements of cerebral blood flow velocity. And cerebral spine, mainly this cerebral spine may be to indicate if there is any cerebral trauma after the head injury. As we know that spinal cord, it is connect, as there's a connection of the, when we talk about the brainstem, if you remember the anatomy physiology, as I have mentioned, the brainstem, that it the center that connects the cerebellum to the spinal cord. So there is a connection between the brain and the spinal cord. So if a person is having head injury, so there is also a chances that there will be injury to the spine. So cervical spine X-ray, it is mainly done, that means to check for any trauma in the spine. In the management, the goal of management, that is the prompt recognition and treatment of hypoxia and acid phase disorders, control the increase of ICP or intracranial pressure. Now the medical management, mainly it involves the ventricular supports, management of fluid balance and elimination, as there is so much loss of fluid because of bleeding, management of nutrition and gastrointestinal function. So here mainly you need to understand here, a patient with head injury, within the 24 hours of head injury, mainly we need to keep the patient NPO, especially if the patient comes with a history of nausea, vomiting, headache. So we need to keep the patient NPO. Only if the patient becomes a bit stable, so we will move forward with the nutritional and the management of the patient, either through rice tube. So next, that the initial management of client with head injury, mainly it involves the management of airway, breathing and circulation, or we need to follow ABC. Now in the initial management, as I've told, that we need always to keep in mind ABC, ensure the patient's airway. Now we have to stabilize the cervical spine, as there is a high association of cervical fracture with head injury. We need to administer oxygen to the patient. Now establish the intravenous access with 2 large bore catheter, and we have to infuse the normal saline or RL to the patient, that is to maintain the balance of blood pressure. Now external bleeding can be controlled with a sterile pressure dressing. We do not attempt to remove any foreign objects or penetrating objects from the wound, because there will be chances of profuse bleeding. So assess for rhinorrhea, otorrhea, scalp wounds to detect the leakage of CSF, remove the patient cloth, intubate if necessary to maintain the oxygens and to lower the intracranial pressure of the patient. Now on the ongoing management, here mainly it includes maintaining of the cerebral perfusion, make the patient warm, by using blanket, warm intravenous fluid, warm humidifier oxygen. We need to monitor the vital sign of the patient, the level of consciousness of patient, the oxygen saturation of the patient, so that the patient can maintain the normal oxygen saturation, that is between the 90% to 100%. Cardiac rhythm, that there should be a regular cardiac rhythm. GCS score of the patient, it should not less than 8 or 7 score. Otherwise, if the patient score it is less than 8 score or 7 score, immediately, because the patient is in need of intubation. So the pupil size and reactivity, administer the fluid cautiously to prevent the fluid overload and increase intracranial pressure. You need to check for the intake and the output of the patient. There you need to check the balance. So there shouldn't be any negative balance or so much positive balance. So you have to be careful about this. So the cerebral metabolic rate is mainly reduced with sedative paralytic agents, or what we call the muscle relaxants, antipyretic, barbiturates, and hypothermia. So the morphine is mainly used to reduce pain and it can be given intravenously. So the paralytic agent or the muscle relaxant, that helps to relax the muscles. Osmotic diuretics, mainly this is given. Osmotic diuretic mainly given that is to reduce swelling as well as to increase the urine output of the patient. So you will see mainly head injury patient, we always refer the osmotic diuretic, that is 25% mannitol, that is should be infused over 30 to 60 minutes. Next, anticonvulsant or the anti-seizure drugs. Mainly it should be given because you know what happened? People with head injury, they are at risk of seizure during the first week after the head injury. So the phenytoin, we need to give it to the patient to inhibit the seizure activity in the motor cortex. Then calcium channel blockers, barbiturates, the pentobarbital, that is mainly to reduce the brain metabolic rate and reduce the intracranial pressure of the patient. Next, we'll come to the surgical management. So surgical management is always required if there is subdural hematoma, epidural hematoma, depressed skull fracture, and penetrating foreign bodies. So here, an epidural clot may be surgically evacuated through borehole or craniotomy. Borehole, it is a hole, you know what happened in borehole? A hole is drilled into the skull to release the pressure due to hematoma. So due to hematoma or edema. Next, that is craniotomy. In craniotomy, mainly the surgical removal of parts of the bones, that is mainly the parts of the bone from the skull, that is the bone flap, what we call, that is removed. It is removed temporary and then it can be replaced back after the brain injury. So it can be removed so that the patient, so that the doctors, they can mainly do the surgery, or they can ligate the blood vessels. So if there is any wound, so there will be debridement or removal of the tissues, and as well as it can be done to evaluate the depressed bone and remove the free fragments. Now in the nursing management, as a nurse, we need to notify the Glasgow Coma scale of the patient. That is very important. We need to assess and monitor the neurologic status of the patient and determine whether the CSF leak has occurred, or we have to monitor for the sign of increase in intracranial pressure, loss of consciousness, abnormal pupils response, vomiting, increased pulse pressure, bradycardia, hyperthermia. Observe for the CSF leakage. Note for contusion about eyes and ears. We need to perform the cranial nerve, motor, sensory, and reflex assessment. We need to assess for the behavior that warrants the potential for injury to self or others. So these are the few nursing management that as a nurse we need to, like, it is the responsibility of a nurse, so that we can help for the early detection of the disease. So that's all about today's class. So I hope that you understand my class. So if you have any doubt, so please kindly message me in the group or chat. We can chat in the group. So please, I want you all to open the textbook and go through about the nursing diagnosis that is related with head injury. So thank you so much, my dear students. So I'll be sending you a content